You would like to hope so, but as you can imagine, it all depends on your experience. And if you're, let's say, a community physician somewhere in the middle of Illinois, you may spend your entire career not seeing these kinds of patients, or within 10 years you may see one or two. So a lot of it will depend on the referral patterns and the size of the community. But I think most physicians are trained to pick up on diverse subset of neurological disorders and signs that would ultimately allow them to, do the right radiological studies in order to find out what is going on with the patient. So while the disease is rare, I think it's within the scope of a medical practice to do a neurological exam and pick up on certain nuances that would then lead you to do some imaging and try to understand what's going on with the patient. I think it goes back to the human aspect of it, right? I think anytime you have a problem, be it a lump in your breast or brain cancer that you find out, it's scary. So it's a little bit of a relative thing to say that one is more important than the other. But I think you are right. Being told that you have something in your brain is profoundly alarming to most people. We have a policy, for instance, of Northwestern of seeing patients right away. So if you call us, for instance, today, we will see you same day or within 24 hours because we try to alleviate some of the fears which may be real or not. Oftentimes we get referrals of patients with presumed brain cancer that turns out to be benign, so that's comforting to a patient, or something that looks like brain cancer but is not really a brain cancer, maybe an infection that we can treat. If it in fact turns out that you have a form of a tumor that we're concerned about, we try to work with the family and educate them about the fact that this is a stepwise fashion in terms of the approach, that given the variety of brain tumors, we can't really assume the worst until we first establish the diagnosis. And then working with a team of other doctors, we try to basically take them through the process day by day. And even when we deal with the worst and sometimes most horrific diagnoses, we still focus on the science, on the clinical trials, and the fact that we always can offer hope and an opportunity to do something that hopefully will make their lives longer and better and more meaningful. So it depends. If it's a benign tumor, sometimes we elect to watch it. So there are a subset of tumors that, for whatever reason come to be diagnosed because let's say you were in a car accident, they take you to a hospital, they do a CAT scan, they see something, but it's unrelated. So we can follow those conservatively over time. Others where we recommend surgery because, for instance, your neurological function is at risk. You are starting to lose vision or something that is important. Versus those that are really alarming to us and aggressive, where we offer either a biopsy or a resection, depending on the location. And ultimately, the treatment does depend on the diagnosis. Given the variety of brain tumors, like I said, some can be managed conservatively, some just require surgery and nothing else. And those that are most aggressive will go on to receive both chemo and radiation therapy. I'd like to think that any surgical field has an element of precision. When somebody's operating on your heart and doing an anastomosis of your vessels, that's very precise work. When vascular surgeons do carotid endarterectomies, that's precise work. When we operate next to the optic nerve or the pituitary, that's also precise. I think maybe what makes neurosurgery a little bit higher risk is that the consequences of an error carry more sometimes profound consequences that are irreversible, simply because the nervous system does not regenerate and is not very tolerant to mistakes. So you're absolutely right. There is an element of what we do that I think carries a higher risk simply because the brain is not forgiving. Well, innovation is really, I think, part of any academic medical center. So one of the reasons I think to come to an academic medical center is because there is an element of innovation there that ultimately will trickle down to a lot of the private practice offices and let's say neurosurgeons in my case. Being in an academic center allows you to be at the forefront because whether you're doing research or whether you're collaborating with companies or whether you're trying to develop new technology, there is a process where we sort of slowly evolve this into patient care through IRB approved clinical trials and emerging technologies in a fashion that is consistent and not harmful. So it's not just that somebody comes up with an idea that there is a new laser and we're going to try it, but really in a thoughtful and methodological way of making sure that yes, we're going to try this technology, but it has to be done in a sort of scientifically rigid fashion that will allow us to validate the data and ultimately make it available to others if there is some benefit to it. So one of the advantages of being at an academic medical center is that you're always bombarded by the latest in terms of technological advances or scientific advances or whatever it is that enhances patient care both inside the operating room and outside. It's a hybrid, I think, right? I mean, there are many things in life that have stood the test of time and they just work very well. That doesn't mean we shouldn't be open to the possibilities of doing things better, but that has to be compared to what we're doing. And again, I think one of the beauties of the surgical field is that people tend to be open to innovation, to engaging new technologies, but they're always comparing this to sort of the old-fashioned way of doing things to make sure that it actually is better for the patient, that we are cost sensitive, that this provides some benefit in terms of efficacy or outcomes or patient satisfaction. And all of those things come to play a role, I think, ultimately in making those decisions.